Hello and welcome to another episode of the Health Notebook. Today we have Dr. Shahieda Adams in the studio, and she's an occupational medicine specialist, and we'll be exploring the topic of occupational asthma or work-related asthma. Dr. Adams, welcome to the studio.
Thank you.
Dr. Adams, can you maybe tell us a little bit about yourself?
Well, I'm Cape Townian. I studied at University of Cape Town, did my undergrad studies as a doctor here, spent a very short time in general practice and really got interested in occupational health very early on in my career as a doctor. I then went on to do the diploma in occupational health and performed sessional work mainly in industry. A little bit later, after sort of having gotten married and had my family, I decided to specialize in occupational medicine and was afforded the opportunity to pursue this at the University of Cape Town. So in 2007, I graduated with my specialist degree in occupational medicine. I was the first one through the program, as it was the first time that it was offered in our country.
Okay. Now in terms, just to inform the viewers, the viewers normally know about the dermatologist where they go and see a person for the skin, they know about a surgeon. Can you just inform the viewers, what does an occupational medicine specialist do?
So the discipline of occupational medicine is centrally interested and involved with evaluating the relationship between workplace exposures and ill health. So it looks at whether exposures cause disease or injury in the workplace, and is also concerned with factors that could mitigate or prevent those kinds of illnesses.
Okay, so it's the environment around the work that influences
Exactly.
health.
It's very much workplace context and how it affects your health.
Okay. Now you've completed your master's, you've mentioned to us, and then you also went on to do your PhD.
Yes. I went straight into my PhD about a year after completing my master's. My PhD dealt with serial screening of healthcare workers for TB infection. Healthcare workers is a particular passion of mine, looking at their particular hazards. I then went on to do a short stint in the corporate sector, and also worked in local government for 3.5 years, providing a clinical service to workers of a large municipality. I've been back at University of Cape Town since last year, and I'm currently employed in a joint post with the Department of Health and the university. So essentially, I'm located in the Division of Occupational Medicine in the School of Public Health, and I am the head of the Occupational Medicine Clinic at Groote Schuur Hospital.
Okay, and then being the head of the Occupational Medicine Clinic, your referrals, where do you get your referrals from?
So we accept referrals from the public sector, from the private sector, from doctors working in occupational medicine or primary healthcare doctors. Occasionally we have the odd case that's self-referred because there's very limited capacity to diagnose occupational diseases or evaluate occupational health problems in the country. So sometimes people phone us up. Usually I vet the referrals, but we get referrals from private, public sector, occupational health nurses, occupational health doctors, trade unions, sometimes NGOs as well.
Okay, so just to inform the viewers, you've mentioned about the work environment. Can you just elaborate on some of the content that is covered in occupational medicine and occupational health?
Okay.
So for example, illnesses or injuries and the non-clinical aspects.
So if one sort of has to divide the discipline into three, then I would say the first part of it is developing skills in performing risk assessments, which is essentially an evaluation of the workplace with a view to identifying the hazards and evaluating the potential to cause harm to health. And that process is called risk assessment. The second part has to do with the diagnosis and early detection of any occupational disease or injury that might arise as a result of exposure to the workplace. And the third part, where we also required to have lots of skills, is in health service management, as it were, to be able to run an occupational health service, to prioritize how money should be spent, what health and safety programs would benefit the workplace, etc. And as an academic, we are also centrally interested in research and what that brings to the discipline. So evaluating whether interventions work, evaluating what the sort of best ways to diagnose, for example, occupational asthma, etc.
Okay, now going to the topic of occupational asthma. Can you briefly define what is occupational asthma to the viewers out there?
So I prefer to use the term work-related asthma because it's a little bit wider. So it's estimated that of every 10 cases of adult onset asthma, 1 to 2 cases are actually work-related. So people who develop asthma for the first time as an adult. So it's a huge problem. It's very under-recognized. But if one thinks of it broadly in categories, then work-related asthma can either be asthma because you've become sensitized to a chemical or some exposure in the workplace.
Okay, can you maybe give us 1 or 2 examples?
An example would be flour dust or latex. If you work in healthcare, if you're wearing latex gloves, you could become sensitized or allergic to it, and that actually can give you asthma. If you're a baker working in a bakery and you're exposed to flour dust all the time, you can develop allergy to the flour dust, and you could end up having asthma.
So it's aspects within your environment that can trigger off asthma.
That's right. However, there are some substances which can irritate the airways, and they cause irritant-induced asthma. So it's not always that the mechanism for causing your asthma is an allergic one. So if you think of chemicals, spray painting, for example, we find a chemical called isocyanate in spray painting, and we've seen quite a few patients exposed to isocyanate through spray painting developing asthma, not necessarily always on an immunological basis. However, other cases of irritant-induced asthma would be things like chemicals like chlorine. Say there's an explosion of a chlorine container and you're exposed to high doses of quite a toxic gas, you could end up developing asthma as a result of that high dose irritant exposure. It's also now recognized that other chemicals, even in low dose over a long time, can cause you to develop asthma.
So it is
sulfur
those
dioxide,
repeated exposures.
Repeated low dose exposure over time. And then there's a category of patient who already has asthma, and you'll pick it up if you listen to their childhood history, who then seem to have an aggravation of symptoms when they are exposed to certain hazards in the workplace or certain chemicals in the workplace, and we refer to that as work-aggravated asthma. So all 3 types, occupational asthma, which we think of more as a sensitizing asthma, irritant-induced asthma, as well as work-aggravated asthma, are all compensatable under South African compensation law.
Okay. Now, just to explain to the viewers, right, now you've defined them into 3 categories. How could you expect the particular person to present, or how do you, if you could give them some type of idea how to recognize that they have occupational asthma or work-related asthma?
So one of the ways they may present is they may tell you that they've developed asthma for the first time. They have asthma symptoms, they've never had it before, there's not necessarily a family history, and they can often tell you, well, I've been 2-3 years in the job, my symptoms are worse when I'm at work, I seem to get better when I'm on leave, my symptoms disappear. Halfway through the day my chest pulls tight because I think it's this chemical. So it's making the link between the workplace exposure and the symptoms. So they have what we call work-related symptoms, and there's clear exacerbation when they're at work and exposed, and there's periods of being relatively symptom-free or having a lot less symptoms when they are away from the exposure. That's the sort of classical history that one would want to get. Then there are people who say that, I've had to use my pump maybe once a week. But I find that since they've introduced the sulfur dioxide at work and I have to work with it, I'm having to use it 4 or 5 times a week now. So there's worsening or aggravation of asthma symptoms. Those should all alert one to a possible cause of a work-related exposure, aggravating or causing the asthma.
Okay, now let's assume you have a potential patient coming to you and you've taken the history as you've mentioned. What would be your next step then? You have the patient in front of you.
So we would like to confirm a diagnosis of asthma. So we would evaluate them clinically, we would do lung function testing. If we've identified a potential allergen that they might be exposed to, we would actually do a blood test or a skin test to actually check, are they allergic to the flour dust or the isocyanate or latex, etc. What we would also do is we do a test which is run over about 4 weeks, where we teach them to monitor their own lung functions and to record it for us.
Okay.
And that is called serial peak flow monitoring.
Okay.
So the little test, they blow into a little meter and they measure something called their peak flow, which tells us how well the airways are functioning and whether there's any obstruction, which is what you would expect in an asthmatic.
Okay.
The other hallmark of asthma is that they have variable airflow obstruction. So there are times when they will have very normal lung functions, and there are times when the airflow will be very obstructed and very abnormal, and that can be picked up. When we see that the bad readings are more related to the times that they are at work, then we evaluate that as a potential work effect, and that is objective evidence that in fact something in the workplace is causing the poorer lung functions.
Okay, so you've seen the patient in front of you, you've taken the history, you're suspecting it is a work-related asthma condition. What would be the next step as an occupational medicine specialist now to verify that this is as a result of the exposure in the workplace? So how do you negotiate the situation?
If the patient is not quite able to tell us exactly what the agents are that they're exposed to, and that's often the case. People don't know what they work with. They know they work with chemicals, but they can't always tell you exactly what it is. So what we sometimes actually do is a workplace visit, where we request the company to allow us permission to access the workplace, where we can actually go and evaluate the work tasks and evaluate the exposures and check what chemicals are they exposed to. We would then, if it is not known whether this can cause asthma, we would actually have to do a little bit of research, read up, and then basically you look at your history, you look at your clinical assessment, the results of all the testing you've done, as well as the exposure information that you've gathered, to decide whether this in fact is work-related asthma or not.
Okay. Now, let's assume you have confirmed that this is work-related asthma. What would be the next step? Because, if a person, if it is his job, he is concerned now, am I going to lose my job, or what's going to happen to me? Do I need to be placed out? So a lot of those thoughts goes through an individual's mind. What would your approach be?
Okay, so in terms of the Compensation for Occupational Injuries and Diseases Act, we have to report this as medical doctors. It's an occupational disease that's reportable and compensable under the Act. So we have to report to the employer that we have seen your employee and we think that this is occupational asthma. And we also report to the Department of Labour. What we would usually then ask is for them to see if they can accommodate this person. So the Labour Relations Act allows for workplace accommodation. So it can take different forms. It might take the form of moving the person, if you can, away from that area. If you can't, it might take the form of seeing whether you can isolate the process that's releasing the fume or causing the exposure. Can you isolate it so you have less people exposed to it, or it's a closed kind of process? Because remember, this might not just be of potential harm to that patient, it might actually affect other people also down the line. So we would provide recommendations around managing that workplace exposure so that it doesn't continue to have the harmful effect it is having on the patient. So it could be things like substituting the substance, enclosing it, protecting the worker with respiratory protective equipment, etc., or moving him to a different area altogether.
Okay, so there is a number of mechanisms available, and is this mentioned in any pieces of legislation in terms of?
So Labour Relations Act says that where an injury or disease is caused by a workplace exposure, the onus is on the employer to try and accommodate that employee.
Okay, so what you've mentioned is the reasonable accommodation.
The reasonable accommodation. Yes.
Okay, so let's assume you've exhausted all the options, you've gone through the reasonable accommodation now. What next?
So, we report it. If ideally the person should be placed. If the person can't be placed, then unfortunately sometimes one has to weigh the potential risk to that person's health versus his job security. And we do find that some of our asthmatics, particularly in the smaller workplaces, that doesn't necessarily have the sort of diverse kinds of processes where they could move people around. Some people do actually end up having to be retired on ill health grounds, particularly if the asthma is severe. There is the option of just moving them to a lower exposure area.
Okay.
You know, that you can't perhaps manage to stop the exposure altogether because it's part of your work process, but you can move them to a lower exposure area. So a baker, we would say, instead of making him knead the flour and mix and get all that flour dust exposure, move him to confectionery where he's doing more wet mixing, etc. And so there's less exposure to dry flour dust, which would irritate the lungs and cause bronchospasm.
Okay, so I mean, this also highlights the communication aspects between the medical doctor and the HR department within the working environment, because there needs to be the communication line so that they understand that this particular patient is unable to perform that particular function. So you operate in a multi-professional, multidisciplinary
Yes, we do communicate with all stakeholders. It's a lot easier for us if there are occupational health staff based in that workplace, in which case that would be our first port of communication. And often we would get the referral from the occupational health nurse or doctor because we think they are best placed to assist with managing the whole workplace accommodation issue.
Okay.
However, when that is not possible, we do speak to HR people who are also involved in placement or redeployment and advise on where we think would be the safest or what would be the safest sort of options in terms of safeguarding the person's health. Because the problem with ongoing exposure is that the asthma gets worse with time, you know,
Yes.
and it doesn't get better, and it impacts on people's quality of life. It may lead to impairment and long-term disability, etc., which are all things you ideally want to avoid.
Okay. I know we've covered quite a bit, and we've also covered the reasonable accommodation, but part of the process is also ensuring follow-up via the patient that needs to come see the medical professional. In terms of the compensation side, I mean, can you just highlight how important that is as well?
Okay, so I think it's important because we need to get a sense of what the burden of disease is, and occupational disease is generally very underreported in South Africa and globally, but very much underreported in South Africa. So the value for us of reporting is getting to see how many cases we have, where are those cases coming from, which industries are the high-risk cases, etc. In terms of the individual case, the value for that person of having it reported is that it is now documented with Department of Labour that there's a workplace exposure that has caused your illness or disease. So if the person ends up having some impairment at the end of it, he will be entitled to some compensation.
Okay, and then how would you go about quantifying the impairment?
So there are guidelines, there are circular instructions for work-aggravated asthma, for occupational asthma, and for irritant-induced asthma. And the parameters that they generally look at is lung function. So they look at what we call a forced expiratory volume in 1 second, but it's a lung function test that measures how well you can exhale, how much obstruction there is when you actually breathe out. So that is the one criterion they use. If you're above 80% of what you expected or predicted to blow, that is considered normal. If you're below that, you get a score.
Okay.
Then asthmatics, often one can get them into the normal range in terms of lung function, but often they need quite a lot of medication to control their asthma. So the other parameter we look at is medication use. So where you are on inhaled steroids or oral steroids, for example, would be the worst. Where you're on continuous oral steroids to control your asthma, you would get a very high score, impairment score. So the score that you get from your lung function and the score that you'll get from your medication use gets added up, and an impairment score gets calculated. And your percentage payout will be based on that.
On the impairment score.
So that is very much within the compensation fund's ambit to do that assessment and adjudication. But the way the instruction is written, it's very easy to work it out.
Okay.
If you sort of have the expertise, you can basically see my patient is going to be found 40% impaired and should probably be entitled to this degree of disability.
Okay. In terms of medication, can you just explain to the viewers what medication would you give, and is there a variation in terms of the normal asthma medication?
So we would start off in a very, very mild asthmatic who now and then has an episode of a tight chest or bronchospasm as we call it. We would start off with an inhaled bronchodilator as needed. So that is the metered dose inhaler, and you have to teach your patient inhaler techniques because these medications are expensive. If they're not using it properly, the dose is not being delivered in the lung. But this is your patient who maybe gets 1 or 2 episodes a week of a tight chest. When someone is using his inhaler a lot more because it's a lot more symptomatic, you need to add what we call an inhaled corticosteroid. And that has to be given quite regularly because there are 2 problems in asthma. The one is that you have twitchy airways, that the muscle in the airway goes into spasm because it's reacting to an allergen or an irritant or something like that. And the other problem is that the airway is quite inflamed. So your bronchodilator helps for the muscle spasm to relax the airway and open it, but the steroid helps for the inflammation. So that's inhaled steroid is the mainstay really of treatment. Then there's a category of patient where that is not sufficient, and nowadays we would add a long-acting bronchodilator. We might go on to add a newer type of drug which is called montelukast, which is a leukotriene inhibitor. So that hasn't been written into the guidelines and is not currently considered when they evaluate impairment. But there are newer drugs available. It's your really brittle asthmatics where we go into oral steroids, which is not ideal, but there's a small percentage of people where nothing works.
Okay.
Because oral steroids, are high doses of medication. It has long-term side effects which are not very pleasant.
Okay. Now, I know occupational asthma is treated holistically as well. Now, in terms of smoking, what role, just some advice to the viewers on the influence of smoking on occupational asthma?
We advocate very strongly that our patients should stop smoking because it makes asthma control really difficult, and they keep losing lung function with resultant impairment and disability. And also with smoking, you tend to develop fixed obstruction. With asthma, the obstruction is variable, which means that in between your lung functions could resort back to normal. With fixed obstruction, with time your lung functions just decline and you never quite get back to normal. It would also then predispose you to intermittent infections, which needs treatment with antibiotics, etc., because smoking impairs your immunity, your lung immunity. So we advocate very strongly for our patients to stop smoking.
Okay. We've reached the end of the show, Dr. Adams. Is there any particular take-home message that you'd like to give the viewers out there in terms of occupational asthma?
So for those patients who think that their work exposures might be aggravating their chest symptoms, I think it's important to raise that with your doctor. Where you feel it warrants further investigation, I think they can, the doctors are welcome to refer to us. We are at Grooteskier. We run a clinic on a weekly basis. We accept referrals from GPs, from occupational health practitioners, etc. I think it's perhaps more of a message to doctors, which is to ask their patients what it is that they do and to try and inquire about exposures, particularly an asthmatic who seems to just be getting worse for no clear reason, or someone who develops asthma de novo as an adult, so out of a new onset asthma in an adult. It's to ask about your occupation and to try and pick up, is there anything in the workplace that might be causing or aggravating these symptoms.
Okay, so there you have it from Dr. Shahieda Adams, the expert's view on occupational asthma. It's about taking note about your environment and what influence does that have on the individual that can lead to the diagnosis of occupational asthma. So thank you for watching, and what you will see at the end of the show is my recent trip to Colombia, and I was hosted by a family, and I'll leave you with those particular clips, and it's also where I spent Eid in Colombia. So thank you for watching. Stay tuned for another episode, same time, same place next week.
doctor en casa. Espero que no sea la última vez que lo podamos tener en esta casa y aquí en Colombia. Le agradezco muchísimo su visita y espero tenerlo muchas veces más acá. Okay?
Okay. And
I can translate a little.
okay, that's
We
what.
are very happy with your visit, doctor, to our home. Actually, I'm from Egypt, but I'm having with my wife, with Colombian wife, and we are appreciating too much your visit for our home and my new home here. And she was saying that we hope that this is not going to be the last time in our home. That means that you are going to be invited again.
Okay.
And we hope also to go to South Africa, since I'm from Egypt and also from Africa. And I wish also to take my wife and my mother and to go one day in your beautiful country, South Africa.